Yeah, sure, sure. Friends and very respected seniors who have joined today's webinar, I welcome you all to the 7th webinar series of Indian Nuclear Society. On behalf of Indian Nuclear Society and on behalf of my own webinar committee and on my own behalf, I have a great pleasure in welcoming Dr. Badwe, who is such a renowned doctor, having done a wonderful job for the human being, mankind, and his challenges are something that we have to listen through him. And we are really lucky to have him today in our webinar series. So I again welcome him to this webinar series. So before I call him, I'll request our President, Shri S.K. Mehta, who is the President of INS, to give his opening remark.
I am S.K. Mehta. It is again an honor and pleasure for me to welcome Dr. Badwe, a well-known research worker in the field of cancer and the director of the prestigious institute like Tata Memorial Center. It is a very rare occasion that we learn about all the things they've done. And I'm sure that we will get educated in many aspects of cancer, the do's and don'ts, which will help us in our daily life from there. We are therefore looking forward to a very informative lecture and a lot of education. Please, Dr. Badwe, accept our greetings for the institute and your staff for doing such a frontier research in these very complex areas, which is a great thing for the humanity. You are not known only in India, but you are known world around that one. So our greetings to you and to your staff, and we welcome you again for this lecture. Thank you very much.
Yeah, before we start, we will have introduction of the speaker that will be done by Dr. Ramanamurthy.
Okay, good afternoon. Am I audible?
Yeah.
Well, I join the others in welcoming the distinguished, accomplished, and renowned cancer expert, Dr. Rajendra Badwe, for the INS webinar series talk. Allow me to now present some of the salient highlights of his career and achievements. He was born in Mumbai in 1956, a bright student and winner of Athalya Medal for Maths. Dr. Badwe graduated in medicine in 1978 and completed his post-graduation in general surgery from Bombay University. He worked in several institutions of repute before joining Tata Memorial Hospital, Mumbai, as the head of the Department of Surgical Oncology. He is currently the director of Tata Memorial Center. Dr. Badwe is an internationally recognized expert in oncology, and some of his noteworthy contributions include development of breast cancer care strategies, development of disease management and research protocols, integration of delivery systems, improvements in quality of cancer management programs, and capacity building of trained human resources in cancer care management. His pioneering work on timing of surgery for breast cancer has been instrumental in creating a paradigm shift in an understanding of this aspect in the treatment of breast cancer and optimizing the treatment regimen. His contributions in areas such as circulating tumor cells, DNA in solid tumors, clinical research methodology, epidemiological research in oncology, and management of oral cavity cancers have enabled a better understanding of the cancer biology and in the development of life-saving treatment patterns globally. Dr. Badwe has published over 167 research articles in various peer-reviewed international and national journals. He serves as a peer reviewer for many journals such as Lancet, Cancer, British Journal of Cancer, International Journal of Surgery, Annals of Oncology, Indian Journal of Surgery, and the Indian Journal of Cancer. He has also served as a member of the editorial boards of journals like the Breast International Journal of Surgery and Mammology. He is a mentor for developing cancer care strategy for the Government of India and WHO. Despite his busy schedule and onerous responsibilities, Dr. Badwe contributes actively to cancer awareness programs worldwide and is a regular speaker in national and international forums. Under his stewardship, TMC was twice bestowed with the honor of making the plenary session presentations at the American Society of Clinical Oncology annual meeting during the last decade, which is a rare honor for any cancer center of the world. Dr. Badwe holds memberships of several professional bodies and committees such as the WHO Guidelines Committee, Breast Cancer Global Initiative, ICMR Task Force for Breast Cancer, DBT Chronic Disease Scientific Committee, MCI Committee for Planning, Super Specialty Training, Mumbai University, HS Academic Council, HBNI Academic Council, Association of Surgeons of India, Indian Society of Clinical Oncology, Scientific Review Committee, TMH, Women's Cancer Initiative, Board of Specialty in Master MCH, MCI, and many others. He is a recipient of several prestigious national and international awards in recognition of his stellar contributions in cancer care. These include the Padma Shri in 2013, Lal Bahadur Shastri National Awards for Excellence in Public Administration, Academics and Management in 2013, and awards from the National Cancer Institute, US, as well as the Union for International Cancer Control, amongst others. There is much more to the man than I've been able to bring out in the short time available, and I hope Dr. Badwe will forgive me for leaving out much more than what I have actually been able to include. So without further ado, it is now my pleasure and privilege to invite Dr. Badwe to commence this presentation. Over to you, sir.
Thank you. Thank you very much for that very fantastic introduction that you made, Dr. Raman Murthy. Dr. S.K. Mehta and Dr. Ramarao, I'm grateful to Indian Nuclear Society for giving me this opportunity to share some of my thoughts on cancer in India. And what I will try and do in the 30-35 minutes is to delve into what cancer has done in India, what we have done to it in India, and how do we compare with the rest of the world, especially the developed world. And I will say at the outset that if there is anybody who has this myth in the mind that West is best, then I would definitely want that opinion revisited by the time I finish my talk. So let's look at cancer in India. Can I have the next slide, please? Dr. Ramarao, if I can have my next slide, please.
Just a minute, just a minute.
Yeah, sure. I'm sorry, because there's some technical glitch at my end.
Yeah, just a minute.
For me to run the slides at my end.
Yeah.
Yeah, perfect. Thank you. Thank you so much. So, as Dr. Ramanamurthy had mentioned that I had the Atle Gold Medal in maths, I will be using lots of numbers and I will show you some stats also. But I'll try and explain it in such a way that it is made easily understandable. So let's look at some numbers. If you look at these numbers in US, UK, urban India, semi-urban India, rural India, these are numbers of cancer patients per 1 lakh population per year. Every year, out of 1 lakh Indians, about 40 to 50 Indians get cancer in rural India. This number in semi-urban India is 60 to 75, and in urban India, it is 90 to 100. The same number in United States is 325. You might say that we are missing patients in rural India. And I would have agreed to this about 30 years ago. But in the last 30 years, we have been running cancer registry at least 4 different locations in rural India. And in these 4 locations, we do a house-to-house survey. In each of these sites, somewhere close to about 500,000 to 1 million individuals. And there is no cancer. The cancer is between 40 to 50 per 100,000. And as we go from these rural pockets to semi-urban India, maybe a place like Miraj, Aurangabad, or Ludhiana, Vishakhapatnam, any of these areas which are more than mid-sized towns, the numbers jack up to about 60 to 75. And if I look at Mumbai, Delhi, Bangalore, Kolkata, Chennai, it will be 90 to 100 per lakh per year. All these are per lakh per year, and these are age standardized rates. So one can't say that in some areas, say in US, the life expectancy is high, so cancer may be high. No. I'm talking about age standardized rates, and that's the rate, 325 per 100,000. Now, as we look at the census every decade there is 5 to 10% transition of a rural pocket becoming semi-urban or a semi-urban pocket becoming urban. And this 5 to 10% transition within the following 2 to 3 years increases the incidence of cancer from 40 to 50 to the next number, 60 to 75, or from there to 90 to 100. So it is this transition, and one must understand that urbanization is inevitable. We are going to face urbanization. Everybody wants it, the kind of comfort that is available in all aspects and a better quality of life. Although I must say, after being in urban area for too long, we do crave to go away and spend some time in the rural pocket. But I wonder whether we would like to do that permanently. That doesn't happen too often. But we are beaten hollow by the numbers in US and UK, 325, 3 times what urban India experiences. What is fortunate is these numbers of urban, semi-urban, and rural have remained constant in India for the last 2 decades. So if you pick up an urban pocket, it has had between 90 to 100 for the last 20 years. Same thing is true for rural. Unlike the other BRIC countries, Brazil, Russia, and China, there is a true rise within urban pockets, the incidence of cancer. So we are fortunate. We are much better off than other developing or upcoming areas globally. And it will be probably unfortunate if we were to reach the number of 325. So let's look at how do we deal with this and how are we faring as far as mortality is concerned. Next slide, please. So why is there such a big difference between US and India? And you have these numbers of prostate, lung, colon, the intestine, large intestine, oral cancer, breast cancer, uterine cervical cancer under United States and under India. So there are 2 different columns here, and there is a word S in bracket in some of these cancers. That word S indicates that this cancer is screened in United States. We are not screening it. Look at prostate cancer. Why is the number there is 325 versus our 100 in urban population? Look at the numbers. Prostate cancer 50 versus 9 in cities of India. Lung cancer 60 versus 10 in cities of India. Large intestine 55 versus 6 in India. Again, all 3 cancers have been screened. Oral cancer is opposite. They have just about 4 per lakh population per year. We have about 23. This is obviously related to, and the difference between 60 and 10 is probably because of the smoking habits. Now, if you look at the smoking in India, one can't say that it is not there. It is there. But if you see a common Indian smoker, he rarely inhales it deep inside the lungs because it's a very hot smoke. And if the ambient temperature is more than 34, 35, 6, 7 months of the year, it will be discomforting for an individual to inhale that smoke and then feel comfortable about it. So we tend to be oral and laryngeal smokers. That's typical of India, and hence oral cancer is more in India and not so common in United States. Lung cancer, there, with the ambient temperature being sub-zero, at least in 6 months of the year, the possibility of little comfort drawn out of hot smoke would be a lot more than what would happen in India, and they have a lot more lung cancers. Suffice to say that oral cancer lends itself to early detection and lung cancer does not do that. And that's the reason you will find that the mortality is extremely high related to tobacco-related cancer in the United States compared to India. So that's about oral cancer. Look at breast cancer. It's more than 100 per 100,000 in US and about 30 per 100,000 in India. This number 9 per 100,000 in Barshi and in all other rural pockets is so remarkable that Bill and Melinda Gates Foundation have pumped in more than $2 million in Barshi project to understand what is it that women in rural Barshi are doing that breast cancer is so low, and can they borrow something from there to take to United States so that the breast cancer there reduces. So although we may want something to be imported from United States, there are few people with wisdom in United States who feel that something from India can also be imported out to United States. Uterine cervix is United States 7 per 100,000, strongly screened for a very, very long time. In rural India, it is about 24 per 100,000, but in Mumbai, about 3 years ago, the number was 7.5 per 100,000. So we are almost similar in cities between United States and India. We are no different at all. I will show you some data to say how different are we at other cities. There are some unique cancers in India. There is liver cancer, which is not so much there in that country. Gallbladder cancer is absent in that country. Nasopharyngeal cancer is extremely rare in that country. And these three cancers are extremely common, not everywhere in India, but in some parts of India. It's common in Punjab, it's common in UP, it's common in Delhi, it's common in West Bengal, Bihar, and whole of Northeast. So there is something unique about cancer in these regions, that there is big difference there versus even Western India. Say, for example, gallbladder cancer in certain group of individuals in Northeast would be about 20 per 100,000 per 1 lakh population per year. That in Mumbai would be 0.02 per 100,000. So 20 and 0.02 is a huge difference. About 1,000 times different more in some regions. And that's where I find that there is something unique happening in these areas. And this is a unique Indian problem and we need to look at it. Next slide, please. Let's look at death rate. I just now mentioned that there are some cancers related to tobacco that lend themselves to early detection. And that doesn't happen for cancers in the United States. And there it is. The cancer mortality in India per 1 lakh population is about 64.5, and that in the United States is 105.8. So there are a lot more people dying of cancer in the United States compared to India. But if you look at those who get cancer, The survival in India is 50%, whereas that in US is 70%. Now here I put a word of caution that in pursuit of improving survival from 50 to 70, if our mortality increases from 64 to 105, that will be unfortunate. So let's look at not increasing the numbers and yet improving the cure rates. And how do we do that? Next slide, please. So let me summarize whatever I have said up till now. Our cancers in cities are about 1/3 of what US has and 1/6 of what our rural population experiences. So of these, whether rural or urban cancers, 75% are almost preventable cancers. Imagine we are already 1/3 or 1/6 of US and almost 3/4 of these cancers are preventable. 40% of cancers are related to tobacco in India. 15% of cancers are related to obesity. Breast is one of them. And another 15% are related to cancer of cervix. I mean, they're related to infections, whether it is cancer of the uterine cervix, stomach, or penile cancers. Now, I must say that in urban India, these cancers are on the wane. So there is something happening that infection-related cancers are reducing at a dramatic speed, at a breakneck speed in cities of India. Cervical cancer is reducing, stomach cancer is reducing at a breakneck speed, penile cancer is reducing to a very great extent. So let's then try and see what we can do about each of these. I'll focus on each of them distinctly. Let's look at tobacco. Next slide, please. About 1 million tobacco deaths. These are not just cancer. These are tobacco can produce hypertension, tobacco can produce heart attacks, tobacco can produce stroke, and tobacco can produce cancer. So there were documented 1 million deaths in 1 year, 2010, due to tobacco. Next slide, please. And this is the data from UK, and we have already got some data from Mumbai, wherein there were some stoppage of the packeted gutka, and there is already a reduction in oral cancer in city of Mumbai. So what is important to understand is the last line is of never smokers. Lung cancer incidence in them is somewhere, it contributes to about less than 1% of individuals ever get lung cancer since they are non-smokers. Individuals who have smoked for some time and stopped at age of 30, they stand at about 2%. Those who have smoked up to 50 and stopped, they stand at about 6%. And those who continue smoking, the incidence is rising as we speak. So what is important is that never smoker to continued smoker, there is a huge gap, and that is preventable. Next slide, please. So prolonged use of tobacco kills, and anytime stopping works. It does work, and one needs to have that gumption, that courage to say that I will stop, and one can stop. I have at least about 5 or 6 of my friends who, after having explained what things can go wrong with tobacco, have just dropped it like this. There's no question of I will reduce from 20 cigarettes to 10 to 5 to 2. That doesn't happen. From 20, you have to stop right away. There will be some withdrawal symptoms, but get rid of them. I mean, tolerate them for about a month, and things are okay afterwards. Next slide, please. How do we tackle from government point of view? There is an excellent formula of tripling the tax, which halves the use and doubles the revenue for the government. I'll give you some example. Next slide, please. That's the effect of tripling the tax in that. This is the French experiment. That's how the consumption rose between 60s, 70s, and 80s. And then the price, the taxation increased from 90 onwards, and there was a drop, a significant drop to pre-1950 by the time we reached 2010 in France. Whereas the taxation related amount, the prices rose by 300%. So that's the percentage rise in the price of tobacco, and that's the incidence of consumption. Next slide, please. Whereas the income for the government doubled from 6% to 12%. So obviously there is no loss as far as the exchequer is concerned, and yet there can be stoppage of tobacco-related ailments, and that will also reduce the cost that is incurred by the exchequer through healthcare, because the need for healthcare will also reduce. Next slide, please. So I will wind this up saying that stopping of tobacco reduced cancer, it reduced hypertension, it reduced heart attacks and strokes, it reduced the burden on healthcare in general, and it reduced all-cause mortality. So the death rate excuse me, reduced remarkably with stoppage of smoking. And we need to follow exactly the same, which we have started in cities of India. It's just a matter of stopping chewed tobacco as much as possible. There are legislations that will stop it. Sale in and around the hospitals and educational institutes is banned, although it is not followed. The second important thing, somebody who chews tobacco produces about 6 times more salivation, because tobacco is an irritant. So salivation increases remarkably. And with no stretch of imagination, that individual can swallow that much of saliva. So he has to spit, and spitting is not allowed in public. That's a law. We just need to implement that law, and I'm sure we should be able to reduce consumption of tobacco, and that will reduce all these scourges, cancer, high blood pressure, heart attacks, strokes, and will make us healthy, reducing the death rate related to tobacco. Tobacco on an average makes one lose at least 10 years of useful part of life. So life lost between 40 to 60 is about 10%. And that is something that is huge as far as tobacco usage is concerned. Next slide, please. Let's move on from there to infections. I did mention that the infection-related diseases are reducing remarkably in cities. Let me first focus on food preservation. Food preservation in majority of the rural pockets is very poor, and food cooked on the previous day or previous evening, stored overnight, is consumed the next day, or cooked in the morning, sometimes consumed the next day morning. And that food can have certain products, some certain chemicals, certain nitrosamines, which can induce certain types of cancers, whether it is stomach cancer, whether it is nasopharyngeal cancer, which uniquely happens in Northeast, where smoked food is consumed very, very rampantly. There is nothing wrong with consuming smoked food, but smoked food that is not preserved properly. If you go to any of the Northeastern kitchens, you will find meat hanging from the roof on top of the chulha, and it is supposed to get smoked over a period of days. So it's not a well-preserved meat, but yet it is consumed, and that's what produces this cancer, which is non-existent in Western India, Southern India, and Northern India. So if we were to preserve, say, the Department of Atomic Energy were to give some nice food storage components in Northeast, I'm sure lots of stomach cancer and cancer related to the nasopharynx will reduce remarkably. Let's look at running water and personal hygiene. In rural pockets, majority of the men have their bath at the common well, and they would have their half trousers or something, the undergarments on while having bath, the possibility of genital hygiene being preserved or maintained is zero. Now, this gentleman, if were to transmit this during intercourse to his wife, the possibility of transmitting the HPV virus is extremely high, and the concentration of virus will also be high because of poor hygiene. And the incidence of this cancer in rural Barshi is about 24. That in Mumbai is 7.5. In Mumbai, 30 years ago, it was 22. So there is, and we have not done anything there. There is neither vaccination, no screening, nothing has been done. And yet it has reduced only because of the personal hygiene. And you might say there are so many aspects that are changed between a rural pocket and cities. Why do I say that it is only personal hygiene? I want you to focus onto the Muslim population in Barshi and Muslim population in Mumbai. In Muslim population, the incidence of cervical cancer is 5 per 100,000 per year in Barshi. It is 5 in Mumbai. It is 5 in Middle East. It is 5 in Hyderabad. And that's because they have this religious belief of undertaking circumcision at birth. The preputial skin in penis is cut off, and that guarantees personal hygiene. So penile cancer in men and cervical cancer in women is Muslim population is close to unknown. And this is not a new observation. This was observed as early as the Boer Committee report in 1940s. There is another elegant report from Dr. Khanolkar of Tata Memorial Center way back in late 1940s and 1950s that these are the cancers which are confined only to Hindus, Christians, and it is absent in Muslims. So obviously there is, I'm not asking everybody to undergo circumcision, but suffice to say that personal hygiene is vitally important and it needs to be taught. And I was visiting a family in Rajasthan, in Jaipur, and they had some dictat rather, written down years ago, that who is to do what in the family, that the man has to earn money, offer protection to everybody in the house, woman has to see that cleanliness in the house, and see that the fresh food is cooked. I'm not saying that that should be done today. Women are capable of doing a lot more. And in that diktat was also written duties of the grandmother. And grandmother was supposed to teach the grandson between age 9 and 11 genital hygiene, how to clean the genital region. And this is unique. This is so very unique that the cleanliness being attempted prior to age 9, when there is an entity called physiological phimosis, wherein the preputial skin cannot be retracted prior to that and should not be retracted because it induces another problem called paraphimosis, which is a very painful condition. So it is in medicine that we are taught that it should not be done, but it was there, written about 100 years ago, that this is how a grandmother should teach the grandson, and it should be taught between age 9 and 11, not before that. So these things are there. Obviously, our ancestors knew what was right and what was good. We just need to follow that. We then move on to, suffice to say that infection-related cancers are on the wane, they are reducing, and we have an easy way of reducing with a cafeteria choice. It could be personal hygiene taught appropriately or a circumcision performed. Or the third new option, which has come from the West, is of vaccination. I will deal with that shortly. I move on to obesity. Obesity is an urban scourge. if you see obesity in United States, it's rampant. And that's the reason cancer there is 325. And even that today is an underestimate. The recent most estimate is 350 per 100,000. And obesity induces about 18 different cancers. It induces 18 different cancers. When I go today and every year to various schools to talk to children, the scourges of tobacco and how tobacco should not be started, because I find that malleable minds need to be imprinted there and then, rather than those who are already on to it. And while I talk, I also talk about obesity. And I find that very unfortunately, all children today, when I visit the schools, good schools, are roly-poly. They're fat. And at the end of my talk, when I interact with parents who are usually there for these talks, almost all ladies, all mothers have this complaint that the child doesn't eat. And I wonder, if the child is not eating, where is this fat coming from? Obviously, there are two things contributing. Our children don't know what is hunger. Hunger is a word they read in books. I remember as a child, before going to school, I was a poor eater then. And my mother used to be after me. Please have this, please have that, please have this glass of milk. And at the end of all that, my grandmother used to quietly tell my mother, leave him alone. Just don't ask him to eat. Let him go without eating anything. Let him feel hungry. Let him understand what hunger is, and then he eat. My mother didn't agree to that, although I was very fastidious in my eating, and I didn't gain weight till the time I crossed 40. Now I am also roly-poly, but it is essentially diet. And in today's world, it is the couch potatoes. The outdoor games have vanished. Our children are sitting on the couch, playing with their computer, playing on television, and that's how the time passes. So it is the obesity that produces at least 13, 14 different kinds of cancers, and it is very much in our hands. How do we do that? Safe cycle tracks. If the present roads have dedicated cycle tracks with the 100% guarantee that no vehicle can run cyclists down, I'm sure there'll be a lot of them who will cycle. I remember when I was at Guy's Hospital in London, the head of pathology used to cycle about 30 kilometers, 30 miles, not kilometers, miles every day. Come there, have a quick bath, get into his jacket, do his work for the day, again get off onto his bike and cycle back home. This should be possible in Mumbai. I was talking to the Development Planning Authority of Mumbai that we have this coastal road. My suggestion to them was, please make this coastal road a double-decker road. Let there be two roads, one on top of the other. The upper is for vehicles and the lower can have 3 travelators, the travelators that we use on the airport. And each of the travelator can be a kilometer or 2, and then interruption for about 30 feet, 20 feet, and then another travelator of kilometer or 2. The first travelator should move at 5 kilometers an hour. That's the speed at which you walk on the footpath. So when you start walking on the footpath, you can step onto it without any problems. You start walking on it, you walk at 10 kilometers per hour. The travelator moves at 5, you are moving at 5, so you are technically moving at 10 kilometers an hour. The next travelator should move at 10 kilometers an hour. You can easily step onto it. Start walking, you will walk at 15 kilometers an hour. The next travelator should move at 15 kilometers an hour, move onto it and start walking. You will walk at 20 kilometers an hour. The distance in sea of the coastal road from Warsaw to Gateway of India is 18 kilometers. Imagine you can walk from Warsaw to Gateway of India in 1 hour, breathing fresh air of the sea, producing no environmental damage, no pollution. Imagine the whole city walking like this. We would be wiping off majority of the diseases, whether it is cancer, high blood pressure, diabetes, and I'm sure doctors like me will be out of business very soon, and I would love that. The last bit is colorectal cancer, the large intestinal cancer. As I mentioned in my first slide, this is rare. Both cancers put together, it's about 10 per 1 lakh per year. And that number in United States is about 65, 70 per 100,000 per year. So obviously there is something not right there. The diet that that individual has, when somebody in United States says that he is non-vegetarian, his breakfast has cold cuts, his lunch has steak, which is a blob of flesh with no seasonings, no masala, no spices. And when he says that he has vegetables with it, there are probably 1 or 2 miserable potatoes at the corner of that dish, which will remain there. And if he consumes it, he will say he has had his share of vegetables. The night will also have, the dinner will also have the same kind of red meat that is consumed continuously. Maybe it may be pork, it may be beef, it may be lamb, but in general, red meat, and red meat. And that's the reason why that cancer of the large intestine is high there. And it is entirely because of a prolonged contact between this DNA material, DNA-rich material of animal source in our intestinal lining. If you see in evolution, the carnivorous animals have a very short intestine, so that the transit time of whatever they eat, carnivores, whatever they eat is very short. The duration of time that the foreign DNA comes in contact with our their intestinal mucosa is very short. Human intestines are long. They are supposed to be, I'm not saying that we are herbivorous, but they are supposed to be not exposed to DNA for too long. And the transit time in intestine is pretty long. So here it is. How come the intestinal cancer is so low here in India compared to the West? So when I say that I'm non-vegetarian, I probably consume chicken, fish, sometimes lamb, beef, not too often. I don't think many would be consuming that. Pork also is uncommonly consumed. But these 2-3 non-vegetarian material is had with lots of spices. If you see something, a non-vegetarian dish served in the north or in Kolhapur, all pores in your body at the end of consumption of that meat will start pouring out. You will be sweating, your nose will run, your eyes will be running because it's hot, chilly stuff. And the purpose of making it hot is to increase the speed with which it moves through your intestine. It is the transit time. So when I see the impunity with which, or the ease with which somebody in India, in rural India, chops onto or bites onto a red chili or a green chili with every morsel of non-vegetarian, I am amazed. How does he do that? But there is a reason for it. The possibility of constipation in India is extremely rare due to our good diet. And if we were to say West is best, we are inviting trouble. And in general, the kind of fast food that is presently prevalent, hardly any spices. It's a very bland diet. If I were in Gujarati, they would say molu che. So it is that kind of diet that is prevalent in some parts of cities, and that would add to the obesity, that would add to many cancers. If somebody is non-vegetarian and not having much of spices, that's the kind of eventuality that one might undergo. Next slide. Suffice to say that this cancer is uncommon. So that was about prevention. Avoid tobacco, have usual diet that we have. When I say I'm non-vegetarian, I will probably have one small dish of non-vegetarian with which I'll have some gravy, with which I will have some kachumar or some salad. I will also have some vegetables with that. So there are many other things, and non-vegetarian bit is a part of that, the whole dish. So let's be that. We are excellent as far as our diet, and that has reduced our cancers to a great extent. From prevention, I move on to screening. It is necessary that we screen for common cancers. It is not appropriate that we screen for uncommon cancers. The only simile that I can give is right in the middle of Mumbai. If I were to look for a tiger, it's impossible that I will find one. If I were to look for an elephant, again, it will be impossible unless some remote temple within a city has had one or two elephants, one elephant which has been there for many years. But otherwise, to look for an uncommon animal is inappropriate. Look for a common scourge and you will find many. So let's look at the common cancers. What should be understood? The moment you start screening, the numbers start rising. If I were to look for, with a CCTV at a signal, who all break the traffic rules, there will be hundreds who cross that white line and park. But I'm not looking for that. I'm looking for somebody who drives through a red signal and bangs somebody. Now that is the kind of individual that I'm looking for. And I'm not looking for these small felonies. So these conditions are satisfied only for two kinds of cancers. One is uterine cervical cancer in women and breast cancer in women above the age of 50. It's unfortunate that no cancer in man has really shown a great difference as far as saving lives is concerned. So God and medical field has been slightly unkind to men and slightly kinder to women. I think that may just be because there are too many men who are doctors. But remember that uterine cervical cancer needs to be screened after 30 years of age and breast cancer after 50 years of age. But no other cancer today, at least in India, colorectal cancer can be screened, but the cancer is so low in India that it is not cost effective. It is not appropriate to look for that cancer. And let us improve the treatment so that we have cure rates which are matching breast cancer. Next slide, please. Let me think of coming back to what is happening to cervical cancer, and I'll give you some data so that there are lots of individuals who want to know, should I vaccinate my grandchildren? Should I vaccinate my children, my daughters who are between 9 and 12 years of age with HPV vaccination? So what has been happening to current Indian women who are now in their third or fourth decade when they were children? Let's look at that. Next slide, please. You will have to press the button 2-3 times so that I get my arrows on the screen. If you look at in 1964, the incidence was 24.7. Today, to 1912, the incidence is 9 in Mumbai for cervical cancer. Today it stands at 7. So 24 to 7. And what have we done? We haven't done anything. We have not been screened. There is no vaccination, but we have reduced almost similar to the number that is there in the West. Next slide, please. Same thing happened in Chennai. 2 more bangs on the keyboard, and I'll have began with 41, ending with 15.7 in 2012. Today, the number in Chennai is 10. So obviously it is reducing in Chennai too. Next slide, please. Let's look at Barshi. Barshi has an urban pocket now. So urban pocket has reduced from 34 to 15, and now it stands at 12. But the rural Barshi still has 23, somewhere in the middle, even now as we speak. So obviously there is something not right in rural pockets, and hence we need to do something. But suffice to say that the reduction that has happened in all these sites has nothing to do with screening, has nothing to do with vaccination. Next slide, please. This is what happened in Finland. Again, reduction from 15.9 to 3.9, and they have introduced screening after 2010 when the incidence was 3.9. Next slide, please. Cervical cancer incidence has sharply declined in every part of India, and it is declining. One tap on the keyboard, and this has happened without HPV vaccination. Please understand that if I were to look at 1 lakh girls being observed today in 2017, by the time they reach 50 years down the line, about 100 of them out of these 1 lakh, in 50 years, 100 of them will get breast cancer, cervical cancer. Although HPV is high, incidence is high, 1 lakh getting it, but the incidence of cervical cancer is very low. So it is not something that we should be worried greatly. And I would debate strongly. If I were to look at my granddaughter, I would give HPV vaccination at this juncture. Next slide, please. So to summarize whatever I've said, safe sexual practices, even a barrier contraception, property, each of these reduce the incidence of cervical cancer. So changing reproductive patterns, late first child and 2 children adequately breastfed, all of it will reduce both the cancers to a great extent. Use of intrauterine device I mentioned to you, improving personal hygiene in men is what is vitally required to reduce cervical and penile cancer. Better nutrition with least amount of non-vegetarian and opportunistic screening. All these factors have reduced the incidence of cervical cancer. Next slide, please. Then what should we do? And here is a study, no, please go back. Here is a study that Dr. Indranil Mitra ran in city of Mumbai, and this started about 23 years ago, 1998 to be precise. 150,000 women, half of them had a visual inspection of their uterine cervix using acetic acid, and they also had a clinical breast examination done by a skilled health worker, a trained health worker who was a 10th pass girl. Just imagine a 10th pass girl doing this every 18 months for 5 rounds. And then we followed up these women till last year. And what are the results? Next slide, please. 2 more banks on the keyboard. And you see 67 deaths in screened arm versus 98 deaths. There are 75,000 women in each group. And each of them, 1 more bang on the key, and 30% reduction in deaths of breast cancer with a test that cost 12 rupees. Done by an individual who is trained for 1 month in Tata Hospital, and the girl is 10th pass. Imagine such a simple intervention. If I were to do pap smear in United States cost $109. Imagine exactly same results by a simple test and no additional overdiagnosis. Nobody unnecessarily diagnosed, but 30% reduction in death. What happened to breast cancer? Next slide, please. When I look at the breast cancer data, can I have the next slide, please?
Just a minute.
Yeah, okay. Sorry. And even with breast cancer, you will find that there was a 30% reduction in deaths due to breast cancer by the time, there it is. 30% reduction, these are the deaths in control arm and these are the deaths in screened arm. there is a 30% reduction in deaths by a plain simple clinical breast examination performed in women after the age of 50. Again, cost to the exchequer, hardly any. So low cost technology preventing deaths. There was a very elegant trial performed long time ago, 30 years ago in United States, wherein physical examination that is performed in this study was combined with mammography, and that reduced death rate by 30% then. But we didn't know what contributed. Was it physical examination or mammography? And then the Canadians ran even better trial. They compared physical examination versus physical plus mammography. So how much mammography added to physical examination? And that trial has had a 20-year follow-up with no difference in death rate. So here is a trial that showed physical examination reduces death by 30%. And there was a Canadian trial that showed that mammography did not add anything to physical examination. Here is a very Indian data that tells you that least amount of additional diagnosis and 30% lives saved in all women who are above the age of 50. Below 50, even mammography is ineffective. Everything is ineffective, and we are trying to learn what will improve the outcome. But I must say that breast cancer is not very common below the age of 50. We see it more often, but because our population is young, we have a lot more women. If I were to see Tata hospital data, 60% of women who come to us are above the age of 50 and 40% are below the age of 50. But if I look at the population, that 40% is contributed by 80% of our population, and only 20% contributes above 50 to the 60% of cancers. So cancers above 50 are extremely high. Cancer below 50 is not very high. Next slide. I will wind up my talk saying that if we were to say no to tobacco, we were to do regular exercise with moderate food intake after the age of 40, vegetarian diet, and those who are non-vegetarian, have it in moderation with adequate spices, if not lots of spices, personal hygiene, screening for cervical and breast cancer, and oral and lung cancer screening for those who are consuming tobacco. I am reminded, and every time I talk, I'm reminded of what my grandmother used to make me recite before I went to bed. And that is fixed in my head, that at 10 years, stop holding your mom's hand. At 20, stop playing with toys. At 30, stop looking around. At 40, stop dinner. Have less dinner. At 50, stop outside food. Now that's impossible today. At 60, continue whatever you are doing since it's the age of retirement. At 70, reduce sour food. At 80, sleep on hard bed for your back. At 90, stop having zest for life. And at 100, stop your life. Thank you very much.
That's great. Wonderful. Thank you, sir. It was a wonderful presentation by you. Really eye-opener to all of us. A message that India is much better as any foreign country in terms of living happily. We can take a couple of questions if there are any.
Sure, I'm unable to hear you properly. Can we stop sharing the screen?
Yeah.
Better.
Any questions?
If somebody can moderate the chat, probably there may be some questions on the chat.
Yeah, you can open the chat.
Dr. Romano, can I ask question?
Yes, of course.
Yeah, please go ahead.
My name is Manchanda. I happen to be the vice president of this Indian Nuclear Society. And Dr. Badwe, it was really wonderful to have heard you. I have a couple of questions actually.
Sure.
You know, this when you talk of tobacco, there's a lot of Indians, you know, they smoke bidi. That is poor people. And also a lot of Westerners, they are fond of cigars. So how do you rate the consumption of this cigarette versus bidi and cigar? That is number one question. Number two question, you know, you had mentioned that these Americans were very fascinated that the breast cancer rate in rural India for women was very low. In fact, it was 9 versus I think some 60, 70 in West. And they are interested in looking into that their cases, what look and they can learn from that. Actually. So I have, of course, more questions, but I want to give opportunity to others. So please just enlighten us. Very informative talk, very useful. So please give your thoughts.
Thank you. So tobacco consumption in any form is hazardous. Whether it is snuff produces paranasal sinus cancer, BD produces oral cancer, cigar also produces lung cancer. So any tobacco consumption is hazardous. Now I will give you an example of in Gujarat. There is a district called Kheda, where that was one of the largest tobacco producing district. And we had gone there to give certain talks to understand as to how the farmers can stop the production. And there was this old farmer, very old, he must be 80 plus. He said that when I was a child, tobacco was used as a compound for all the farms, because tobacco along the compound would stop insects from coming in. Because no insect comes to tobacco. Tobacco doesn't need insecticide. The insects know that it is harmful. And also cattle rarely walks into a farm that has tobacco as its compound, because they smell and they are repulsed by that smell. So tobacco consumed in any form is hazardous, and it can induce cancer.
There is a question: does stress cause cancer?
And the second part is 9 versus 100. Barshi versus USA. If you visit Barshi and if you see women there, they are thin and wiry. They work whole day. They must be doing huge amount of physical work, walking long distance to get water, to get food, and it is impossible that they will ever have a chance of gaining weight. And that's one of the reasons why breast cancer is extremely low.
Thank you.
Khula.
One more.
I have one question. It is always said that in coming years, there will be more cancer cases in India. So according to you, which type of cancer will be predominant?
In women, it is breast and ovary, which is likely to increase, which is increasing even now as we talk. And in men, it is essentially tobacco. There would be obesity-related cancer, which is the lower end of food pipe, large intestine, kidney, breast and uterine body uterus cancer. All these are related to obesity.
Balkrishna, Gopal Balkrishna. Badwe sir?
Yes.
I just want to ask you one thing. What is the present development with the kind of a technology for pathological determination with few cells with a mathematical algorithm? I have said it somewhere, I have read it. With few pathological sample screening and with a mathematical algorithm, they are able to interpret the early diagnosis of cancer.
Okay. Now, this is explored in US as very, very early diagnosis. But please understand that I gave you an example at physical examination.
Please unmute your mic.
Yeah. So early detection is possible by these cellular mechanisms, but how much of precision will improve outcome is equally important to understand. Physical examination by a trained individual, either a doctor or a healthcare worker, will pick up cancer which is 1.5 centimeter. Mammography will pick up less than 1 centimeter, but there is no difference. Mammography does not save lives. Now here, what I would like to give an example that the changes, the cellular changes or molecular changes happen in every cell. Every cell has this mind wherein a little corruption can happen. But when I start picking up, I will give you data. If 100 women, sorry, not 100, 1,000 women who are ostensibly normal, were physical examination, about 1 or 2 of them might have breast cancer. If I were to have the same 1,000 women undergoing mammography, this number 2 will become 4. The same 1,000 women undergoing MRI, this number 4 will become 8. God forbid nothing should happen to these women, but there have been autopsy studies. Women who have died of vehicular accidents in various parts of the world have had their breast examined under microscope. And the cancer, frank invasive cancer, was seen in approximately 230 women out of 1,000. 230. So this never manifests. What manifests needs treatment. The only parallel I can give that I mentioned earlier, that I am not looking with the CCTV as to who is crossing that white line where people park their car. I am looking for somebody who will cross brake signal. And the same parallel, somebody has his mic open somewhere. Anyway,
yeah, I think we
doesn't
should
matter. If I were to draw a parallel, that metal detector frame in airport, if that were to detect past or present corrupt thought in human mind, I wonder how many of us will be able to walk through it. I won't be able to walk through it. But we are not looking for that. We are looking for somebody who will pick up an AK-47 and fire at people.
Good evening. I am Gopalan.
Yeah,
my question is, your very informative talk we had, and I am very happy that the rate is cancer affected patients are coming down, but of course population increasing. So my question is, it appears that hyperthermia treatment, that is one of the pillars it has become now, it seems, other than the surgery and radiation and chemo. Where in India the hyperthermia treatment cancer is available?
So we don't have robust evidence to say that hyperthermia actually saves lives. There are some few studies, not very reliable enough and not very robust enough in design to say that hyperthermia adds to cure rates. So it is not yet across the globe anywhere available. It's available only in few centers which are practicing based on very meager evidence.
Because unreachable places like brain, that may be a boon. That's what
Brain is an area where very few things are difficult to do, because very few things are possible to do, because one can't be radical the way we are radical in stomach, radical in breast, that I can remove the whole organ. That's just not possible for brain. We have to be extremely conservative. And even 1 centimeter margin is not possible to take, because that will produce a loss of function somewhere. So there is a problem there. There are various new things that are coming up in brain where we may be able to save some lives. But high-grade tumors in brain remain not conquerable.
Thank you. Thank you.
Doctor, there is one question about the stress. Can stress also cause cancer?
There is no direct evidence that stress produces cancer, but stress can induce excessive eating, can induce hormonal changes that can induce obesity or excess estrogenic phases, and that may induce cancer. But stress by itself is not related to it.
One more question. Any correlation between alcohol intake and incidence of cancer?
There is a direct correlation between alcohol intake and prostate and liver cancer, but it's a very small one. I would say there is. If I were to say there isn't, I will be wrong.
I think we have taken enough questions. Now I will request our webinar committee member, Mr. Dharne, to summarize his talk.
Dr. Ramana, can I say one last thing? There is a question about prostate cancer.
Yeah, please.
And prostate cancer is something which is rampant as the age advances, but rarely does it become a killer cancer.
Okay.
So in United States, because of screening, if I start screening, exactly the same thing. If I start screening, I'll have a lot more cancers.
Okay.
Act of observation that allows a lot more things to be picked up. But the purpose is to reduce death rate related to cancer, and that doesn't happen with prostate cancer. In fact, the American trial that you looked at screening for prostate cancer, there was more deaths when screening was done.
Okay.
So you look for something, you get more and you kill more.
Okay. So Mr. Dharne will now summarize for the benefit of all the participants.
Good evening. Am I audible?
Yeah.
Yes.
Thank you, Dr. Badwe, for a very fantastic talk and the great illuminator of the whole thing. I am very happy to be here because we are on the same stage for probably after so many years. We have been together on stages and taking big bats and abuses from the people for when we are talking about Jaitapur project, and then the way you were explaining to the people, the alienating their fears that, okay, there is nothing wrong with the radiation, etc. So after that long time, we are together. So I'm very happy. And as usual, as you were at that time, you are the best orator. And the way you have picked up the topic, the way you have expanded the topic and substantiated with so much of statistics, the numbers, and your own experience in the field, that is fantastic. That's great. And generally, we Indians are fascinated by, I'd say, white skin. So you have very aptly told us that West is not the best. And in the field of cancer, we are far better off. Obviously, because of, as you have explained, that it is because of our habits, our upbringing, our food, our lifestyle, and the way we go about in the life. So you have very nicely and with very great confidence, you have covered that what are the causes of cancer, what are the maximum rates of the cancer and because of what, and essentially how keeping our lifestyle proper, how we can conquer, if I can say that, we can conquer the cancer, like keeping the obesity at minimum, do not follow the American lifestyle and try to become a Yankee, then leave the tobacco, which is one of the great harm substance. So talking about all these things in the cancer control strategy, you have given us a very good insight into how we ourselves can fight the cancer and be happy. Similarly, the things or the change in the lifestyle which we should bring on, you have very nicely explained with your example of cycling tracks and giving numbers, and absolutely feasible thing. Whether it will happen or not is a different thing, but if we can really walk from Warsaw to Gateway, that will be fantastic, I would say. Today, even at per, I mean, your estimates would be probably 1 hour or 1.5 hours for reaching. Today, if you really start with a car from Warsaw to Gateway, If you start in the morning, probably you will reach for the lunch only. So rather than having a car, it would be better to walk down. The next thing which I really loved was Tamda Rasa and Pandra Rasa. You talked about the Kolhapur and the correlation between stay of the non-vegetarian food in the intestine and the DNA contacts. That was great. And it also tells us that the lifestyle which has evolved for last so many centuries has really a basis for it. And it is really good for us. It's very happy to see that, as you have stated in your statistics, that the cancer is declining in many areas, barring a few areas. And that's a great, what you can say, a hope that, well, the whole nation is becoming healthier, at least in the area of cancer. So a fantastic talk, backed up by numbers, backed up by statistics, backed up by your own experience, and a very clear-cut thinking into what you have said. Thank you very much, sir.
Thank you, Mr. Dharneji. Now I'll request our INS Secretary, Mr. Malhotra, to give a vote of thanks.
Malhotra, unmute.
Unmute.
Unmute yourself.
I think before I propose a vote of thanks, our president probably wants to say a sentence or two.
Okay.
Mr. President, you may kindly unmute yourself.
Mehta Saab, unmute.
Well, first of all, let me congratulate Professor Badwe for a very, very informative, simple facts of life, making every fact of life very simply forward. These are the daily observations, but we always ignore that. I do not want to ask many questions, but I would like to have his permission to present this talk to many of the members and on the even to the college or schools wherever we have the contacts. So do we have your permission, sir?
Sure, no problem.
Yeah, Malhotra ji.
Yeah. Hello, friends. Very good evening to all of you. And now I have a pleasant job to do, proposing a vote of thanks for today's webinar. First and foremost, I thank profusely Dr. Badwe for, as usual, no surprises, such a wonderful, authoritative and pleasant talk. It's always a pleasure to listen to him, because one thing is you are listening to an expert in his own field, and second thing is he puts things, even complicated things, in such a pleasant manner that you really don't realize that how much time has passed and how long he has been speaking. So Dr. Badwe, if you recollect, I think we have done so many things together, especially as Dharne Saab was mentioning regarding the Jaitapur project, couple of programs. And today we were recollecting that how after one of your lectures, I think in Mumbai city in one of the halls, when as usual you mentioned that smoking definitely causes cancer, somebody from the audience shouting and telling, it is my choice to die of cancer after smoking and consumption of tobacco, but you have no business to kill me by putting up a nuclear power station.
Yes, indeed.
So I was recollecting that how those people present in the audience, they were reacting to that. Anyway, it was once again wonderful to listen to you, and thank you very much from your. I mean, normally in vote of thanks we say that thank you for giving your valuable time, but here I mean it. Definitely your time is very valuable, not for you, but for your patients, and stealing some time from that and sharing your experiences and expertise with us, with the entire audience. Thank you once again. And I think in future also, whenever we need you, you will be there to help us.
Sure.
Next, I thank our president, Shri S.K. Mehta, and all the colleagues from the Executive Council of INS, and also the convener and all the members of the webinar subcommittee, namely Shri Ramarao, Shri Ramanamurthy, Shri Dharneji, for conducting yet another episode of this webinar in a very smooth manner. And of course, I would like to thank Mr. Shimjit, who always helps us in preparing the publicity material, the poster, etc., for sharing the information about the webinar with our members and other audiences. And last but not the least, I thank all the audience, all of you who are listening to me, who have just listened to Dr. Badwe. Thank you very much for being present on a Saturday evening. I mean, giving your time for this talk. Thank you very much. And before I close down, I have no announcement for the next webinar. We are still working on it. So yes, we will definitely be coming with another webinar. We will let you know whenever it is decided. And before I close down, wishing you a happy Navratri season and advance greetings for Durga Ashtami and Dashera and Vijayadashmi, which is just a couple of days away from here. So signing off, thank you very much. Always be there for our webinars to encourage us. Thank you very much.
Thank you, Malhotra ji. Thank you, Dr. Badwe. Thank you very much. Thank you all. Thank you all.
Thank you.